And thanks everyone for coming here today. It's going to be hard for me to negotiate. This is a long room, but I will try to move as much as I can, making your work with the camera much more difficult. On the slide is my email address, so if there are questions or concerns that come up that you don't get a chance to discuss with me during the presentation, which you're welcome to interrupt at any time, I welcome your email. This is my form of electronic suicide. And then it's also my Twitter handle. How many of you are on Twitter? Yeah, so there's 3 or 4 of you. So if you want to get on with the times and join, or tweet me during the session or at any time. Also, I welcome that interaction. I don't have any relations with any for-profit interests. As Heidi kindly described my research work. When we started doing this work, we decided that we would not take any funding from any for-profit corporations, and so I can put this slide up. And this is true and was true until October. In October, I was able to publish this book that Heidi kindly mentioned called Why We Revolt. All the proceeds from the book go to the organization, patientrevolution.org, so I don't derive any income from it. And I will be mentioning some aspects that are present in the book. But this is not meant to be a pitch for you to go and buy a lot of books and help us with the organization, but rather the core ideas of the book are the core ideas of the message that I have for you today. And let's start, as we should always do, with the patient. And her name is Maria Luisa. She is originally from Peru, like I am. And I would like you to tell me what you see. And I have hearing aids. I have difficulty hearing, so if you can yell out your answer so I can hear it, that will help me tremendously.
Confusion. Lots of medications.
Lots of medications. What else?
Overwhelmed.
Overwhelmed, confused, sad, yes. What else?
Elderly.
Elderly, yes. What else? What else do you see?
Appears to be alone.
She has so she has that's a medical, one of those alerts where you call, you can ask for help. Some of the younger colleagues thought it was some sort of old-fashioned Fitbit. No, that's not it. What else do you see?
By yourself.
By yourself, yes. What else? Yeah, that's actually interesting. She is at home, so she has a fire extinguisher at home. At least these Peruvians are a little fiery, you know, so you gotta have your fire extinguisher. She actually does not live alone. She lives with her son and two granddaughters. In fact, she only speaks Spanish, so this is their main social contact. So those of you who thought she was alone, yes, that is a feature of her life. And if she needs to talk to other people, she picks up the phone and calls families and relatives and friends in Peru. So, so that's that. Anything else? There must not be any dermatologists in the room because they're always like, oh, what's up on the cheek? Anything else that you see? Okay. So yeah, you got it absolutely right. And so Maria Luisa is a representation of probably the most common type of patients that you see in a medical center when you open the doors, mostly for adult ambulatory care. It's patients who live a life in which they've accumulated multiple chronic conditions and challenges. And when they come to see us, their main question is, what is best for me? What is best for my family? And our hope when we actually open the doors, turn on the lights, and start the day is that our care is the answer to those questions. But I'll put forward today that that's increasingly more difficult for a number of reasons, and I think we need a way forward for that. Now, why is it that people like Maria Luisa are some of the most common patient types that we see in our clinics? It's because there are some major challenges and changes in the way society is behaving. At the biggest context, we have violence, we have environmental pollution, we have poverty, we have alienation. And that's creating a very stressful environment for our bodies to live in. This environment is able to contribute to hormones and other things that produce chronic stress. It's isolating us from each other, creating problems of loneliness, which is now being uncovered as a major risk factor for cardiovascular disease, and also is a contributor to obesity, which is also a significant risk factor for chronic disease. So putting all these things together, we really have an epidemic of multiple chronic conditions affecting most of our population. This graph shows that in sort of graphical terms. On the x-axis, you in the bottom, on the horizontal axis, you see the age. Towards your right are the oldest people. The bottom. And what you see as the conditions accumulate is that blue is the time and effort you spend on medications. Yellow is the time and effort you spend on diet and exercise, lifestyle changes. Red is the time that you spend with supervised lifestyle issues or therapy, psychotherapy, physical therapy. And then greens are doctor visits or nursing visits or pharmacy visits. So you can see that for people with chronic conditions, a big chunk of their time has to deal with self-management. This is another way of looking at the same reality, perhaps a little bit closer to home. You know, somebody's diary, where you see notations about life and health care, all working together, weaved into each other, as it happens in our actual human being. Not as a patient, not as a person, but as a person that lives with the challenges of chronic condition and self-care. So when we talk about Maria Luisa being overwhelmed, that is implying that the amount of work that she has to do has exceeded her ability to do it. So we need to understand that there is a work of being a patient. And I would put forward that nobody told us about this work. If you go to any textbook of medicine or nursing or anything like that, there's no chapter on the work of being a patient. It's been a complete blind spot in healthcare. And as a blind spot in healthcare, I think that what it has allowed us to do is to keep transferring additional work to people because it's work that we otherwise don't see. And it makes us look good if we can achieve more without having to invest our own resources, because it makes us look more efficient. So in addition to the work that you've seen, for instance, in that diary, there's more work, there's new work that we're transferring to patients. And all of this, you will see, make a lot of sense, except when you see it all accumulate. For instance, we're asking people to come prepare for a consultation. Right? That's something people should do. They should watch our educational video. We spend a lot of time putting these YouTube videos. Very nice. You get to meet your doctor, get to meet your nurse. They'll explain about your condition and about your treatment, so you should probably watch them. You should bring questions, be ready to ask new ones. We ask you to report, maybe just bring and report the visit. That way I can speak very quickly, and then you can listen to me as the sound of my voice at home, and then you can understand better what I'm saying. We ask you to review the medical record. You know, you can catch some of the errors we sometimes put in there. I know, Mrs. Jones, you don't have a prostate, but you know, it's just a simple thing of copy and paste, but you will forgive me. When you communicate via the portal, I know it's not like your email or like your WhatsApp or like your Facebook Messenger, but you know, it just makes us feel important, so use it. And we want you to transmit the data. If you have a Fitbit, you know, just transmit it. We won't see it, but they told me that that makes you feel engaged and engaged. We want you to self-measure, self-monitor, self-manage, to manage your appointment, your prescription, your bills. Keep your family and important others informed. Take care of significant others, and make sure you advocate for yourself and for others. We're asking all of this of sick people. So, and people are noticing. So this is a survey of Americans over the age of 65, and 40% are saying that they're being asked to do too much. And when they're being asked to do too much, they're delegating some of this work to family members if they have them, to others. But if they have low socioeconomic status, if they're by themselves, if they're sick, some of that work is not going to get done. We made a mistake at Mayo Clinic. We turned on this questionnaire, which is a questionnaire that captures treatment burden, which was supposed to be turned on at another time. Somebody flipped the wrong switch, and all of a sudden we have like 700 breast gaining surveys that included this question. So that, you know, kind of cool. We don't know who answered, but kind of cool. And one of the things that we saw in that were these three areas where people were actually expressing the most burden from the work that we're transferring to them. So the most negative impact on their well-being from the work that we transferred to them. And notice that these areas are figuring out, how am I going to get coverage for this service? How am I going to pay for it? And then lifestyle. You know, what is the right level of exercise and how can I get the right diet and quit smoking? So the lifestyle stuff that we saw before was a very significant amount of the work. It's also negatively impacting well-being, all the demands on that, but also in addition negotiating the administrative aspects of getting the care that one needs. This is where patients are experiencing this most significant burden. Another way of looking at this is what Gabby Spencer did. She's a researcher with our group. She gave patients an app on their smartphone and asked them to use that app to capture the work that they have to do to take care of their type 2 diabetes. And they can use the smartphone camera app to take pictures. They could type in thoughts and concerns, but the app also prompted them to record, have you done anything for your health in the last 3 hours? So we can get kind of just-in-time documentation of how much work and how much effort people put in. So I'm going to show you some of the pictures that patients took. And so all the pictures I'm going to show you are pictures patients took to reflect, to tell us about the work. So of course, in patients with type 2 diabetes, reading food labels is also a significant challenge. Making use of medications and using them appropriately, figuring out how to use them and carrying them around. This one is interesting. This was a glucometer. But it was not about the challenges of using a glucometer. It was that this was the 8th glucometer that the patient had been given by their benefits management, their prescription benefits manager, their insurance. Because every time the insurance changed contracts, that contract came with a new glucometer. So he had to learn a new glucometer, which is free, but also get a new set of strips. And so he had like strips for like 8 different glucometers at home, and they had to remember which one was the one that they were using. Many patients end up giving up on setting up the glucometer. So when they bring it to a practice, I don't know how many of you take care of people with diabetes, but if you hook them up to figure out the data that's in them, oftentimes they're set up to dates in 1945 or things like that. And so there's like, they never collected any data because your software is not going way back to look at what happened in 1945. People are not using the full interface because they've given up setting them up. Many patients showed us this, sitting alone in a room waiting. Either this or in a waiting room, but the pictures of waiting and waiting and waiting. This is not a hospital. This is actually someone's home, and they have set up space to keep up their supplies for their insulin pump. So, you know, the issue of staying organized and doing the work. This patient wanted us to see this because she was doing everything right. She was well organized, juggling family, juggling work, juggling self-management, and she had an accident. And now everything takes longer, it's difficult to move around, and she became disorganized, and that became a real challenge for her. 75% of the patients that Gabby interviewed reported a high degree of treatment burden. And one of the things that she started to notice is that they will allocate them to healthcare. You see another picture of someone waiting. 43% to the issues of paying for healthcare, 34% just to mental exhaustion and managing all the challenges, and 27% to medications. The only one of these that was ever documented in a medical record was the one related to medications, when it affected side effects. But all the other ones are invisible to us, so people are having a negative impact on their well-being from the work we're transferring to them. And we're not only unaware of that work, but also unaware of that negative impact, at least judging by what is documented in the medical record. Our response to when people don't do what we ask them to do, when they become overwhelmed and they don't do what we ask them to do, our caring and loving response is to label them as non-compliant, right? And don't think that you're more sophisticated if you call them non-adherent. It's the same thing, right? You label the people, right? So when we label them as non-compliant and non-adherent, we're labeling them. We're labeling them as a person. We're labeling their character as if there's something fundamentally wrong with them. If you go and carefully look at some of your non-compliant patients, some of them are, you know, single mother with 2 kids, taking care of their elderly parents and holding 2 jobs. That doesn't sound like a non-compliant person, but many of your patients that get that label have very complicated lives and are doing their very best to keep everything afloat. They just are overwhelmed by how much we've transferred to them. So this label describing a person and not their circumstance is of very limited accuracy, but it's also not very helpful. The clinicians in the room, I'm sure, will agree with me that when somebody presents a case and says, I have a 76-year-old woman who's non-compliant, poof, your brain goes like, I got nothing. You know, I'm not going to be able to help this person, right? Because you know for chronic disease that a lot of the execution of the work is in the hands of the patient. If the patient is already non-compliant, nothing's going to happen. So this is not only not an accurate label, but it's also one that paralyzes our ability to help, and it perhaps contributes to poor quality care. So there's a better way of thinking about this. If we have given work that has exceeded the person's capacity to do that work, maybe we need to understand that dynamic, and for instance, understand what are the sources of capacity that people have. And when you look at this list is going to include a lot of familiar elements, things that you're worried about for other reasons. Perhaps you're focused on the social determinants of health, and you will find here that financial, for instance, is in the list. Or social. If you're isolated, if you have no one to ask help from, or you do not know how to ask help, you're going to have to do this all by yourself. And doing everything by yourself means that your capacity is quite limited to what you can do. Physical health, if you have a bad knee, it's going to take forever for you to move from point A to point B. And that means that in your day, you're going to be able to complete fewer tasks. Also, if you're poor, that means that, somebody said that it takes too much time to be poor. Right? Because you don't have money to help you cut corners, to get faster from point A to point B, to hire help, or to get additional support. Literacy, that's pretty obvious, right? If you have limited expertise about your disease or your treatment, you do not know where you can actually cut corners and make things easier. Bandwidth is an interesting one because I think it applies to most of you. Bandwidth has to do with if you're worried about something, if your brain is filled with concern and deep worry, you cannot think straight. You will make poor decisions. And our patients, when they get very sick and also very concerned about how they're going to pay the bills and all that stuff, if at that point we're teaching them stuff, for instance, saying you're in the hospital, you're teaching them about their medications on the way out, you expect them to think through and understand what's going on and imagine how that's going to play out when they get home and when they open up the cupboard and they have more medicines there, and are they the same, are they different, which one is which, and which one is supposed to stop and start. Their brain is clouded, and it's not because they've gotten dumb, but because there's a reduction in their ability to pay attention to the facts that allow them to make good decisions. That reduction in bandwidth is also an important factor that will reduce capacity. So instead of thinking of Maria Luisa as a non-compliant person, which is, is a bad label on the character of Maria Luisa and is a useless clinical diagnosis, perhaps we can diagnose a syndrome in Maria Luisa, which is an imbalance of workload and capacity. This has two features. One is describes her situation, not her. And the second feature that it has is that it immediately points at two possibilities for solving the problem. One is, can we reduce the workload? And the second one is, can we enhance her capacity? And we have a way forward, and we'll discuss a little bit how might we do that. But I'll put forward that to make that diagnosis, one has to notice the person in front of you. And healthcare today is built in to actually blur the patients. We're being asked to take care of people that we see as a biopsy or as a test result, or that we see as a statistic in population health, another one of my diabetic patients, or that we see so fast that it's a blur, that we cannot see them very well. We don't notice their situation in high definition. So we will not notice when they're overwhelmed, like you did. I just had to put her picture up. Maria Luisa had to say no words. And you were able to really characterize a lot of her real situation just by looking. But we are not affording clinicians the time and the ability to focus and look. The agenda for the encounter is often set up ahead of time with a number of must-do tasks, boxes you have to check, things you have to document. And if we have time, we'll get to, why are you here? And if you ask somebody, why are you here? We have a paper coming out that documents, it used to be that clinicians will interrupt patients within 18 seconds. We now interrupt them within 11 seconds. So if you have something important to say, you have 11 seconds, on average, that means 50% have fewer than 11 seconds, to say something before you get interrupted. And the interruption is usually not a what else or a clarifying question, it's just let's move on, because we have other things to complete here. And as a result, clinicians are at a loss. Not only at a loss of how to help this person, but at the personal loss. Clinicians have a higher rate of burnout. Increasing number of clinicians are abandoning or reducing their hours in patient care. They're bringing that dissatisfaction and distress into their personal life with increasing rates of divorce and suicide. So we have tremendous turnover in busy clinical environments that actually also affect the ability to develop relationships and continuity of care. So in that environment, to take care of the most common types of patients becomes a heroic act. Left to the innovation and the motivation of people that are committed to mission, not necessarily supported by the system of care, but often despite the system of care. So then we develop shortcuts to make our life easy. Some of the shortcuts are, oh, let's have them have choice or innovation or some guidelines or targets that are very easy and applied to everyone. And the problem is, of course, that if they help us take care of people like Maria Luisa, but that's not the job. The job is to take care of Maria Luisa. And so we pretend to be doing care when we're really basically doing industrial care, industrial health. Now, when we miss the boat, when we give the recommended treatment to the wrong person, we run the risk of being cruel to them because we just spend their time, we just spend their effort, they just pay attention for something that was not necessary. And oftentimes, this is everybody doing their job, following the guidelines to the T, doing all the work that they have to do, but unable to be flexible, unable to adapt their response to this person. Oftentimes for fear that in doing so, they will lose income or they will lose reputation. They will miss the targets that they're supposed to have. And yet, at the same time, I suspect that everyone in this room can tell me a story of wonderful care occurring in this exact same system. Wonderful care that because there is a chance that it might happen to you almost accidentally, you are willing to hold on to the system as is, rather than lose the possibility of getting wonderful, miraculous, life-changing care. So there's an alternative. And the alternative future, I would like to describe it as a careful and kind care. So not industrial health care, but careful and kind care. One in which the context of our encounter is an unhurried conversation. It doesn't have to be unhurried because we have 3 hours to have a chat. It could be unhurried because it's not cluttered with other industrial agendas that interrupt our ability to interact. People have actually measured the time that clinicians spend looking at the computer, filling in forms and completing tasks, and looking at the patient, interacting face-to-face with the patient, and it's about 50% each. And the 50% where they're interacting directly with the patient oftentimes is to obtain information they need to put into the computer. So it's probably less than 50% time on the patient. So if you're spending a 15-minute appointment, you're really dedicating less than 7 minutes to the patient in that particular way. And we criticize places like Spain, where doctors went on strike because they were having less than 10 minutes to see each patient. And we will say, oh, imagine doing that. I mean, imagine taking care of people with less than 10 minutes. But we may be doing that if we spend most of our time feeding the administrative monster rather than paying attention to our patients. So inherent conversations are necessary so that we can actually appreciate the patient's situation in high definition. Because that situation is increasingly complex. Our ability to fully appreciate it takes time and takes presence, takes focus. We cannot be tired. We cannot be thinking about the next patient or the one before, thinking about, I have to make it to the kids to soccer practice, I'm running late, I need to get, you cannot be in that mindset when somebody's telling you something that is multi-layered, and in fact, they're also hiding something. And you know it in your hearts of hearts, but you're afraid to ask, because if you ask, that's the proverbial can of worms, and then there's going to be crying, and then it's going to be long, and then I'm going to be late, and I'm not going to get to a soccer practice. And then the purpose of this, of course, is to achieve sensible resolutions that advance the situation of the patient. Not to meet the metrics, not to improve this, is to actually improve the situation of this patient. And that is not delivering care, providing care, that is caring. Is caring for and about the patient in front of us. That's the job. Careful and kind care. Not industrial health care, but it's careful and kind care. Now, how might we get practical about some of these things? So I'm going to use a couple examples to look at how we make it practical. So I told you I'm a diabetes doctor. So one of the things that we do in diabetes is we give people diabetes medicines to lower their blood sugars. And we can use algorithms to decide which drugs we might choose, we can use formulary guidance to decide on that, or we can figure out with the patient which diabetes medications are appropriate in their particular situation. And in the process, learn about that situation so we can do a two-for. So in this particular case, imagine a patient that has high blood sugars, is already on metformin, and is looking at adding a second drug. They've tried their diet, exercise, it's not really working, so they're going to use another drug. And so the clinician could choose a drug, or they could ask the patient, well, which aspect of your next diabetes medication would you like to discuss next? And they can look at the titles of these cards. Most patients are concerned about their weight already, so they're interested in knowing that medicines could affect their weight, so they choose the weight change card. And when they look at this card, they notice that metformin, the one drug that they're taking, is weight neutral, but there are a couple of drugs that can help them lose weight. And so they're interested in those. You know, oh, so there are drugs that can help me lose weight. So great, I want to know more about those. So which aspect of those drugs would you like to learn about more? Well, I want to know how you take it. So this is a medication that you inject. Oh, So when the only injectable drug we had was insulin, everybody's like, I don't want needles, I don't want needles. But now we have this one that has needles and makes you lose weight, and people seem to be willing to inject it either. So, all right, so that's an interesting possibility. Here's another one that helps you lose weight, and it's a pill. Oh, so yeah, the pill seems very attractive. Okay, so what do you want to know about that? Well, how much will it cost me out of pocket? Well, you take metformin, and you're used to 10 cents a day out of pocket. This one is about $8 a day. So that's 80 times more expensive. Oh, is 80 times better? No, it's just got 80 times greedier. Oh, okay. So in a person who is very cost sensitive, you will see their eyes go directly to this one they were going to inject their eyeballs with, and they will realize, oh, that's $11 a day. That's not going to help me. And so they're giving up on the weight loss ones, and they found the weight neutral one, pill a day, $7 a day. Maybe I can't afford weight neutral or weight loss. How about a little bit of weight gain? That's pill a day, 10 cents a day, that's my drug. For other people who are maybe less cost sensitive, they're more interested in other aspects, they will arrive at different drugs. That, for instance, may not be the drug that a surgical orderly may choose, knowing that they're going to be in the OR without food for a long time. So different people will identify, and the most interesting aspect of this is to hear people that give you the reasons why they choose one thing or the other. So I'll tell you a quick story about it. This is quite fun. So when we did the trial of this tool, a 92-year-old guy got into the trial. You know, it was like, you normally don't involve 92-year-olds in clinical trials, but this guy got into the trial. And we video record the visits between our clinicians and patients in this study. So we have this video recording of this primary care clinician kind of beat up and tired, you know, kind of sitting on his hand. And we have the camera really going through that triangle between his hand and the head, you know. And we see the face of the patient, the 92-year-old man sitting next to him. And the guy goes, all right, so we're doing this trial now, and we have this card. So which aspect of your next diabetes medication would you like to discuss next? So the patient looks at it and says, weight change. And the guy goes, why do you care about your weight? You're 92 years old. Why do you care about your weight? And the guy goes, well, doc, let me explain to you. So about 6 months ago, my wife died. Oh man, so that was sad. Yeah. 3 months ago, my dog died. Oh, it's a real tragedy. Yeah, it's a real tragedy. Yeah. So I am moving into this assisted living facility. You know, dog. Yeah, that place is filled with women. So at this point, the primary care clinician is perked up, is paying attention. So they've been patient and clinician and have this relationship for years, right? But this is new ground. And these guys are, okay, all right, so it goes through this same exercise we just went through, and at the time there was just the exenatide, which was a two times a day injectable drug, and so the other weight loss pill did not exist. And so the patient goes, oh, I'm interested in this weight loss one. So what else you want to know? How do you take it? So it looks at this, and it's a twice a day injectable medicine. And the guy goes, perfect. So, oh no, why would it be perfect? You're 92 years old, you want to be bothered by injections, you know, you can take a pill. Doc, the nurse comes twice a day to give it to you. At this point in the video, these two guys are doing what you were doing. They were laughing. When was the last time there was a diabetes encounter people laughed, right? I mean, they were laughing, they're enjoying themselves. They're discovering each other. They're developing and furthering the personal relationship between the two. They're not just choosing diabetes medicine. That's not the point, right? This man is entering a new phase of his life at age 92, and his clinician is now getting sense of it for the first time. What follows is absolutely incredible. So the guy prescribes the medicine, he gets denied the medicine because he has to try other things first and so forth. The clinician, this burnout guy, goes to bat for the patient, gets him the drug, and then sends him to the diabetes educator to teach how to inject it. But the order is put incorrectly, and the patient is sent to the endocrinologist, right? So an idiot like me goes to see the patient walks in and says, who was the idiot that put you on this drug? And the patient says, oh, it was me. You see, 6 months ago, my wife died. I went, oh, no. So there's a lot of value in this. And just like you, just like this primary care clinician, in our videos, we see increasingly that in moments of discovery of each other, there is joy in the practice. So it doesn't have to be true that you have turnover. It doesn't have to be true that people have to make moments of human connection despite the system. We can create things in the system like those tools that could actually begin to turn this around and make careful and kind care the norm. Going back to Maria Luisa, we said that she perhaps had imbalance of workload and capacity. What could we do about it? Well, in terms of burden of treatment, we could use tools like shared decision making to try to prioritize what matters to her, or pharmacists can help us de-prescribe and take away some of that burden of treatment. What can we do with capacity? Early in the trajectory of chronic disease, we could train people with coaching and self-management training. We can give them techniques so that it will not be so hard for them, particularly as they accumulate chronic conditions, to cope with this. Palliative care has a major role here. You see, we tend to think of palliative care at the end of life, but most of these patients live with things like fatigue, insomnia, chronic pain, disability. These things that palliative care clinicians are very expert at, and if they would just get out of the end-of-life thing and begin to affect all these patients, I think we will be all getting better at palliative care for our patients and not have problems like the opioid epidemic we have now. Mental health, of course, is very important. Physical and occupational health. Again, remember that knee. That's going to work. I'm going to fix this while I talk. Because I'm good. Let's see. All right. I got it. I think I got it. Yeah. So palliative care, physical occupational therapy. I told you about the knee, right? If somebody has a bad knee and they have to get things done, it would be nice to get a brace, it would be nice to get a cane, it would be nice to get rehab. And so that way you can do all the things you wanted to do. And notice that these are not the services that we normally invest heavily on, right? I mean, obviously trying to get things that are happening in the community to help you out. And there's an incredible initiative in this town, and it's actually furthering the connections between the healthcare system and resources in the community to help folks that I understand many folks are yet to find out about. But these are the kinds of things you want to mobilize to increase the patient's capacity. I'm going to pause, but I'm just going to go briefly through this. So this idea of workload capacity imbalance, if it's out of balance, people are not going to be able to access, use, and enact all the self-care. They'll have bad outcomes, and as a result, they'll be sicker, which will reduce their capacity, but we will respond with intensification of therapy, and as a result, there will be a reduction in their, or increase in their workload, and this will be a problem. So if you're going to be held accountable from a quality perspective, you don't just want to be held accountable on A1C. You want to be held accountable on your ability to manage the burden of illness and the burden of treatment. You want to be able to have adequate levels of satisfaction and seamlessness in transitions of care. And you want to be held accountable not just to disease control, but physical function, mental function, and role function. And it won't stop with clinical care. Your whole institution has to reflect the values of optimizing workload and capacity balance. This is a picture I took from Twitter. I think it's from Vietnam. I couldn't find the original author, but this is a healthcare organization, and these are the patients waiting for service, and they're tired of standing in line, so they put their shoes to stand in line for them. But what this is telling these people is your time and effort is not important to us. This is the message. And in doing that, is lowering the expectations that patients have that when they go for care, they're going to be cared for. But also it's a reflection of the kinds of societies that we have. This is an image at the bottom of a human pyramid in a town in Spain, where they compete with the next door town for the tallest human pyramid they can make. And everybody in the town contributes, regardless of physical constitution. They have a role to play. Children are the ones that are put at the top because they're lighter. At the base, this incredible image forms. Everybody around one. Imagine that every time we fall sick, we have a problem, our whole neighborhood comes around to help us out, to support us emotionally, with materially. Just take the dog for a walk, help me with water my plants if I'm in the hospital, pick up my mail. Simple little things that won't take a lot, but reflect to each person, to the person in the middle, that the whole town is in support of that. We don't have that society, and elements of society that maintain that are falling apart. Institutions that kept this together are falling apart. So not only are we not responding properly, but we are actually a machine. Our society is a machine of chronic disease and a machine of isolating people who are sick. And so we have big work ahead of us, not only to improve the way we respond to the challenges within healthcare, but also to rethink the way we're building our societies, we're building our towns, we're building our communities, and refocusing them on generosity, on solidarity. This is one of those pictures that patients took of all her work, and she wrote this next to in the app. Tonight, as I am taking all the medications to treat my illnesses, I feel overwhelmed. Overwhelmed because I looked at the box I have here in my hotel room and wondered how I keep this all organized. All these prescriptions I take every day, and I wonder if the doctors prescribing all these really understand what this translates to for me. This is a full-time job, but I'm great at hiding it. So, what does Careful and Kind Care ended up looking for Maria Luisa? Turns out, Maria Luisa is the grandmother of Ana. Ana spent a year with her research group studying this idea of minimally disruptive care. And when she went to Anchorage, Alaska, where Maria Luisa lived with her son and 2 daughters, I was able to identify areas where she could do some help. So she got this elevator thing for the stairway. Maria Luisa was very afraid of going downstairs. Remember that little falling thing that she had? And so when that finally left for the day, she was a prisoner of the 2nd floor or a prisoner of the 1st floor. She could not move around. And so her ability to get things done during the day was very limited. This is Anna here to your right. And this picture is taken in a dialysis unit. Maria Luisa went to dialysis 3 times a week. And went in the mornings, and the mornings were busy in dialysis, in the afternoon she was wiped out. So she was living essentially a part-time life. Maria Luisa tried to get her to the afternoons on dialysis, which freed up the mornings of dialysis, and she was able to pick up her crochet habit again. But she got lucky. In the afternoon, 2 of the nurses in the dialysis unit spoke Spanish, and Maria Luisa's social life expanded a bit. The other thing that Ana did is she noticed all the dietary restrictions that Maria Luisa had. And I told you she's from Peru. We Peruvians like our food. And there's a lot of really good Peruvian food. And Maria Luisa tried to have it. And of course, she would get in trouble because it was all out of bounds, right? So Ana asked a dietitian in Peru to convert those requirements into Peruvian recipes and found somebody in Anchorage that would come on Sundays and cook for Maria Luisa for the week. So she could taste Peruvian food without getting in trouble with her multiple chronic conditions. All this work that Ana did, not only as a physician, but as a loving granddaughter, allowed Maria Luisa to go from the pictures you've seen of her, of overwhelmed and perhaps lying down in dialysis, to have enough capacity not only to do well, but to travel back to her home country of Peru. And the last picture that Ana sent me of Maria Luisa is Maria Luisa smiling, big smile, not as big as the enormous fish that she has in front of her. Right? But if I were to ask you, what do you see? You will say health. You will say health. It's almost like we need to make sure that everybody gets their fish. Careful and kind care. So what is the way forward to finish? I think the way forward is to create a system of care that is not based on greed, but it's based on solidarity. At every level, from the society that supports our organizations, all the way to the motivations of our organizations. That is not driven by regulations and rules and incentives and punishments, but is driven by the integrity of people at the forefront of care who are trusted in their training and their judgment. That is not focused on efficiency of doing more with less, but on elegance, no waste, no haste, with things taking the time they take to be done well and not more. With careful stewardship of the resources so they're not thrown away, but we also without shortchanging people by giving them all the same care when they need different care. So that the care is not for patients like this, but the care is always for this patient. And that the interactions are not based on transactions. There are business transactions where you come in for service and you leave, but they're based on relationships, relationships fueled by love. And I've been to a number of healthcare environments in which I mentioned the word love, and it feels jarring in describing healthcare. And somehow profit doesn't. And I think it's an indicator of how far out we are from the real thing that inspired each of us to come to do this kind of work. And it's love. It's our ability to change and improve the lives of others. It's solidarity. That's why we went into healthcare. And I think we have in our generation the opportunity to start the work of changing this from essentially a world of industrial healthcare to a world in which we have careful and kind care for all. And there's an opportunity to do that. And it will exceed the time that we have. It will be one of those multi-generational things, like cathedrals. When towns decided that they had something important that had to be built, they started. And it was generations later that they will have the finished product, if they finish. And it may be this kind of work, that it may take several generations, but if something takes a long time, the time to start is today. And I think that is what is called on us. I want to finish by telling you that this work is the result of a lot of research and a lot of activities that is done. And if you want to participate and further that work, we hold a workshop every year in Rochester. It's in October, so it's not that cold just yet. And so it's nice. The tools, like the shared decision-making tools that I showed you, they're widely available. They're free. You can use them in your practice, and you can review them more at shareddecisions.mayoclinic.org. And the work on minimally disruptive care, the care that Hannah did to help improve the life of Maria Luisa, is in minimallydisruptivemedicine.org if you want to review that material. And again, there's my email and my Twitter handle if you want to continue the conversation. And I think we still have a few minutes for questions here. Thank you for your attention. There's a roving...
No, thank you so much. This was tremendous, Dr. Montori.
Victor.
I really was struck by the tool that you used with the what do you want to talk about for your next diabetic med? Did you have other examples of like general tools that you've kind of widely studied like that?
Yeah, so our most popular tool is the statin choice decision aid, which is a tool that helps patients and clinicians discuss whether a statin is right for you. That is used once every 4 minutes somewhere around the world, so it's widely used, and it's integrated in Epic, so you should be able to find it within your Epic infrastructure. That was actually not put by us in there, by another group that found it very helpful. There is a similar tool for osteoporosis treatment, so for women, they get informed what their bone mineral density is, but what their risk of fractures is, and how much that risk can be reduced with drugs, and we're actually improving that one to include lifestyle changes as well. There is a tool for anticoagulation in patients with atrial fibrillation, and that one is undergoing a large randomized trial testing at the moment, but a tool is essentially done that can be used. There are tools for otitis media treatment for use in the emergency room for ear pain. There are tools for stable angina for deciding between drugs or stents. There are tools for, we probably have about 20 or 25. What this long list demonstrates is that we should not have a practice now filled with implementing multiple kinds of tools, but the idea is that these tools begin to train you as a clinician and create expectations of your patients that some of the important decisions can be made together. What that has as an obvious practical consideration is that the next time an important decision has to be made, for instance, at the end of life, for instance, DNR, DNI, for instance, intubation and ventilation in the ICU, for instance, discontinuation of those surgeries, that this will not be the first time people are going to be asked to participate in making choices, but rather that they have experience participating in making decisions in which the right answer is not evident, and the right answer for each person will be different. So it's really a technique to get us, clinicians and patients, used to the fact that many of these decisions require our participation. Otherwise, we're going to be having a practice where the main task will be to figure out which tool do I need to pull out next, to help a patient. Another question. Keep your questions brief so I can make my answers really long. That seems to be working well. Any other thoughts?
My question is an amazing presentation, absolutely incredible. For everybody in this room, what is one thing, what is the most impactful thing that you think that they could take out with them when they leave and try?
If I had known there was a one thing, it would have been a waste of your time and your energy to ask you to pay attention for a 1-hour presentation, right? And so I would say that, but I will engage, right? And so I think that the one thing I will take away is the idea of careful and kind care. It is not about efficiency, it's not about throughput, it's not about making a lot of, it's not about the financial outcomes. Those are critically important for the success of our enterprise. But they're background stuff. the foreground stuff, are we being careful? And by careful is our care scientific? Is this the right care for this patient, not for patients like this? Are we being careful? Are we safe? Are we making sure that all the safety work that goes into organizations like this is paying close attention? Are we being careful? And then the next word is, are we being kind? And by kindness, are we respecting people's limited attention, time, energy when they come to see us? Are we respecting that? Are we honoring that? Are we seeing them in high definition, understanding their full situation? Are we treating them as a member of our tribe, our kin? That's what being kind is. And are we following the platinum rule, right? Are we treating them the way they would like to be treated? And for that, the only way to discover that is to have conversations and discover who the other person is. Otherwise, we treat cartoons, impressions, blurs of the person in front of us. And we go home, and when our kids ask, what did you do today? Our kids get the same answer we get from them when we ask them, what did you do at school today? Nothing. And there is no way to sustain the kind of emotionally laden work that we do, feeling that when we go home, what we've done for the day is nothing. And I think the best solution for us is the best solution for our patients, is to be able to give careful and kind care to our patients. And so if that's one thing I'll take, that will be the one thing I'll take. Anything else? Something more difficult? All right, well, thank you very much again for your time.